I would like to admit again here that I have also used the AI generated template here to be precise, but the content is all mine. Okay, so to be clear. So I am with Dr. Vikram's team at the moment. So, but ended up editing this document for last night for 2 hours and ended up with frustration. That's what happens when we land up with all these complications, difficult scenarios when we manage ACL injuries. So I'm going to talk about all these one by one and might share my experience of how I handle these in our department. So look at these statistics, as Dr. Chirag also mentioned, not a very exciting one. 65% return to play at pre-injury level, 55% athletes not returning at competitive level. There is more risk of injury to the non-injured side. Most of them lack psychological readiness before return to play. So mostly it's implicated that athletes tend to return to play quite early and they are not ready for return to play, and sometimes our rehab strategies are not appropriate. So that leads to long-term complications and re-ruptures. We need to understand that there are a combination of intrinsic and extrinsic risk factors that we need to identify here. And if we address them right at the start of the rehabilitation, it becomes easier for us to manage them. So we need to form appropriate strategies, educate the patient, and set some appropriate goals, and graded exposure techniques can be used to get the athletes in a better mind space before return to play. Gait impairments very common and very difficult to treat. Often they land up due to a combination of factors such as lack of range of motion, quads inhibition, effusion, and mostly the athletes will have reduced stride frequency, decreased range of motion, decreased extensor torque when they walk. So if you can see the video out here, the athlete walking with a very antalgic gait pattern. Look at the knee flexion stiffness there and lack of knee extensor torque. So pelvis drop on the other side with a trunk shift on the ipsilateral side. So we need to address all these issues right at the start. This athlete, this patient has reduced cadence. He's avoiding to flex the knee while he's walking. There is almost no heel strike that is happening. So he's lacking his heel strike. So it's important that we address all these issues right at the start. This patient is holding a crutch on the unaffected, on the wrong side, so it will promote faulty walking mechanics. So how do we manage this? Is to provide them confidence right from the start and get the appropriate synergies working. So it's a constant feedback process that we do. So until we don't inculcate good mechanics in them, build some confidence in them, they will still land up with faulty mechanics. So it's important that we address hip and knee control when we train them. Arthrofibrosis is very common. It's nothing but lack of terminal hyperextension, even loss of flexion. Mostly it happens in bone patellar bone tendon grafts, mostly common. Or if an athlete is having a lot of effusion and pain. So mostly it's found that there is a lot of tendon stiffness or peripatellar stiffness around. The quadriceps muscles undergo tightness and there is a lot of scarring around the anterior tendons. Some of the research studies found it was a systematic review to see the definitions of arthrofibrosis. They found the definitions were quite varied, and some of the studies used the original Shelburne classification systems, and there are a range of treatment options available there that includes arthrolysis, physiotherapy, manipulation under anesthesia, and even casting. So unfortunately there is no evidence-based protocol for managing arthrofibrosis. It's best treated if you address them before 8 months of surgery is what they found. For loss of extension, best evidence is at the moment for casting. For flexion loss, best evidence is to manage with manipulation under anesthesia is what that study found. From a physio point of view, we can do early manual therapy, earlier the better. So we can do a range of manual therapy techniques like patellar glides, patellofemoral mobilizations in different directions based on your assessment. We can do a lot of stretching programs, stretching, strengthening, a lot of passive mobilizations can be done. Once you get a new range of motion, you retrain the neuromotor system. So you strengthen the muscle in the newly acquired range. Mostly the dysfunctional joint is not adapted to the new range. So you need to retrain that by adding a lot of repetitions into the play, by adding a lot of neuromuscular facilitation techniques. That's the end range hamstring strengthening for loss of flexion that you can do. Quadriceps weakness, again, very common to see arthrogenic muscle inhibition. That's very common to see when you have pain, effusion and swelling. One of the recent reviews, they found physiotherapy and cryotherapy as a mainstay of treatment. So it's again commonly seen in anterior tendon grafts where there is a lot of scarring and pain. Mainly the range, effusion and cords control are connected together, and it can lead to anterior knee pain and further complications. So it's important that you look for prolonged quadriceps weakness. So you can look at quadriceps atrophy, quadriceps muscle girth, you can look at gait impairments, and you can check the quadriceps strength at periodic intervals to manage this. So from a rehab point of view, you can do quadriceps and hamstring strengthening exercises progressively in open chain, closed chain pattern, and a lot of hamstring endurance exercise. Anterior knee pain, again, very commonly seen, and it's often frustrating. Often common in bone patellar tendon grafts. Often it's seen that these athletes will have some hip muscle imbalance along with the knee. So we've talked a lot about having quadriceps and hamstring strength, but it's important that we address the hip strength and hip control in these patients. A lot of times in rehab, we try to overload the anterior compartment. So that can lead to overloading of the patellofemoral joint and can lead to patellofemoral pain as well. So range restrictions, quads weakness and hip imbalance, they significantly interact with the anterior knee pain. So rehab exercises definitely focus on getting full range, especially hyperextension of the knee. In especially anterior tendon grafts, quads weakness is more apparent even at 6 months. So we need to slightly modify the rehab approach, wait for the strength to come back until you initiate any return to play. And it's important that you address hip imbalance or any kinetic chain deficits that are there, or any core stability exercises. Graft failure, again, once it happens, it's difficult that the graft is stretched, it's difficult to manage these athletes. One of the reviews, they found that the common criteria, common reasons why these athletes underwent graft failure was lack of meeting all 6 discharge criteria and decreased hamstring to quads ratio. ACL with concomitant injuries, mainly we struggle with the weight bearing and loading that happens. In meniscectomies, in my opinion, where there are small meniscectomies, that compartment is not that loaded or not that affected if you load it. But in major meniscectomy, we need to be careful of how much loading we are doing. In meniscus repair, especially with meniscus root repairs, it's important that you prevent hypoflexion or flexion until 3 months. So, whereas in peripheral repairs or its gradual progression of loading is advisable after 6 weeks. So it's important to take proper precautions when you load them in close kinetic chain positions. So the bottom line is, if you monitor pain onset and reactive joint effusion while your rehab is on. Same with chondral injuries. Mainly it's the prognosis when it happens with ACL reconstruction is not that great because it increases chances of osteoarthritis. Mostly microfractures and microperforations allow immediate weight bearing, but the transplantation procedures will have delayed weight bearing. So it's important that you discuss with the surgeon as to what exactly weight bearing criteria are, and then allow the healing to happen. Thank you for having me.